hypoactive, or I should say the hyperactive, people are restlessness, agitated. Again, maybe for like the hospital, they're pulling out the IVs, those type of things. Aggressive, et cetera, et cetera. Really make sure that we rule out alcohol use, substance use, those type of things. Some of the best, talks I've seen, is just lately just kind of remind us that people's substance use problems don't just go away because we get older. And it's something that's often overlooked, asking specifically how much alcohol someone uses, rather than just do you drink, yes or no. It's like it's a much different thing if someone has a glass of wine once a week versus someone's drinking 12 beers a day. And if all of a sudden we stop that cold turkey, that's going to cause some problems. We're going to have some drug withdrawals. It's also the good reminder on getting good med rec as people transition from one facility to another, or transition from home to assisted living, home to long-term care, and those type of things. Were they taking certain medications we didn't know about, and now we're all of a sudden just stopping them? Those PRN medications that maybe some people just assume, that they're just really not using, or just every once in a while. It's like, no, they're basically taking them scheduled. And if all of a sudden we stop those things, that can give this hyperactive kind of presentation. Also, we have the hypoactive type delirium, which is a little bit harder to kind of notice or assess. People drowsiness, subtle changes are often missed. So if all of a sudden someone's eating less, if they're sleeping way more than normal, if their mobility is changing, all of a sudden they aren't walking when they always were before, those are maybe things to kind of think about. And this is where we need our providers to help us out on figuring out if there's some medical things going on, getting lab work if we haven't already to make sure there's not metabolic issues. And then we'll talk about those anticholinergic medications coming up, and reminding that it can be on the same spectrum. If people are going from hypo to hyperactive, that can be not uncommon. And so pathophys, the true reason for delirium is not totally understood. The most studied things kind of talk about where that cholinergic and dopamine system are out of balance. Specifically, if we're blocking acetylcholine, so that's why anticholinergics are so often implicated in delirium, or if we have things that are increasing the dopamine in our brain. So again, me thinking from the pharmacy standpoint, if we're adding levodopa, if we're adding ropinirole or pramipixole, which are dopamine agonists, increase, that can cause it. And so then that's where sometimes the treatments and the studies that they've looked at in treating delirium try to look at medications that kind of try to balance acetylcholine and dopamine out. There's also theories, and we definitely know that if electrolytes get out of balance, sodium, if we have buildup of ammonia, different things like that can also cause it. Aging is also associated with altered transmitter balance, so that maybe can increase inflammatory response. Also thinking about as we age, things cross the blood-brain barrier easier. So that's sometimes why we might have struggle a little more with anesthetics or with surgery and coming out of that compared to when we're younger. And it goes along kind of with the medication changes and pharmacokinetic changes. As we age, we tend to have less renal function. Our renal function gets a little bit worse. There's an increase in volume of distribution of some medications, so that can cause some problems. And then overall, slower elimination. And maybe where the thought is here is a lot of times is we're way better at adding medications than getting rid of medications. So, we stay on the same meds for 40 years, and it's like, well, it's always been fine for me, this dose and this medication. Well, it can build up, and then we add on potential interactions. That's why maybe we're having trouble now when we're 70, when we're 80, when we're 90, versus, 30 or 40 years ago. And so taking that into account. So like I said, I'm going to spend a little more time in the medications where a little more of an expert. And what are those medications that we're worried about? And specifically, it's anticholinergics. I probably should have included a list, but like the Beers list has great reference as far as what medications we're talking about. There's a lot of other anticholinergic lists that you can Google. But if we think about some of the classics, diphenhydramine, benztropine, amitriptyline, those are kind of our classic anticholinergics. But the good thing about having some of those references handy is there's a lot of medications we don't necessarily think about. In some of them come up later, skeletal muscle relaxants or trazodone or mirtazapine, some meds that maybe we don't think have a lot of anticholinergic activity. But when we put them all together, we have the person that is on 30 medications, on 20 medications. You start adding those up, that can add to that risk of causing or adding to or contributing to delirium. Urinary antispasmodics, that would be like the oxybutynin. That's kind of another classic anticholinergic medication. Tolterodine, a lot of medications in that class. Antibiotics, as we know, when we kind of have slides, we got to remember that infections, specifically UTIs are a common one in older people of causing delirium. But also think about the antibiotics, the meds we use to treat those infections can also add to delirium. And so cephalosporins, macrolides, like the penicillin G, or fluoroquinolones like levofloxacin, ciprofloxacin, they can cross the blood-brain barrier and add to or cause delirium. And so one example I have here is, this was from a few months back where someone had a UTI, all of a sudden they're aggressive, showing more of those hyperactive type delirium type symptoms. And so the facility really wanted to, and the doctor specifically wanted to add an antipsychotic because of how aggressive they were being. Well, family was really against doing that, and more managing a little more with lorazepam, et cetera. And so I got asked to review that case and what was going on. And I really felt that the UTI started kind of some of those symptoms, especially when you looked at the charting and those type of things. And then the quinolone, the ciprofloxacin, really seemed to accelerate it. And this person had a lot of allergies, so there was reasons why they were doing the quinolone. And I really felt if we could just make it, a few more days, as we're almost done with that quinolone and give it a little time to go out of our system, that those symptoms would go away. And again, it probably took a little longer than we thought, but a few weeks later, there was really no discussion about needing an antipsychotic and those type of things. So it's being aware sometimes of these things, because when we see a symptom, it's so easy to say, well, let's add another drug. But delirium is one of those kind of syndromes that sometimes adding more things can just make everything worse. And where this gets confusing, and then medications that affect the CNS, the first drug on the list are benzodiazepines. Well, that's sometimes our go-to when somebody, we're not sure what their anxiety and this hyperactive states are about. We might need it if somebody's real aggressive. And so I guess the takeaway message here would be, just if we're doing benzos, which we should try and limit to prevent delirium, but if we keep adding more and more, if things are getting worse, let's not keep doubling down, right? And now let's add another med on top of that maybe we start backing off and assessing, are things getting better or worse? Maybe just the more practical approach there. So again, kind of the reoccurring theme, and when you're working up somebody with delirium, is thinking through which meds cross that blood-brain barrier, and what drugs are anticholinergic. And if we don't know that, or don't know how to reference it, that's where to get, our providers and our pharmacists and stuff involved to help us kind of figure out which of those meds. So the certain antihypertensives, like good example there, propranolol. It's the reason why it's good for PTSD and anxiety, is because it crosses the blood-brain barrier and can help us with some diagnosis, but it can also contribute to delirium. Metoclopramide, effects on dopamine can potentially add to delirium. Analgesics, especially opioids, and again, this is where we need good clinicians, assessing what's going on, because uncontrolled pain is also a big driver of delirium. And so we need to treat pain, and there's certain instances when we need to use opioids. But as we add opioids or keep increasing the doses, are we making things worse? Have that in our back of our mind. It's like, let's maybe switch opioids. Let's maybe decrease and change it to something else. Another probably classic example in the opioid realm that we'd see a lot in long-term care is when we use fentanyl patches, probably a little more than we should have. Again, opioids, they don't affect liver, don't affect or cause kidney damage. So they're safe in some ways, but we know the risks other places. And then like with fentanyl patches, people don't have to swallow them, right? The problem with fentanyl patches is it takes a long time for that drug to be absorbed through the skin into the fat, released through the fat into the bloodstream. And in the meantime, so when this is taking a couple days in older people, we're all panicking, right? We're still in pain. Let's keep increasing the dose. Well, when that drug all comes to kind of its main half-life, a week down the road, we maybe overshoot it sometimes and can cause a delirium. And so, again, just goes back to thinking about in kind of peeling this back, and you have a case with delirium, what meds are new? What meds increased? What's changed? NSAIDs crossing CNS, so there's some potential there, not near as much as opioids, I would say. Anticonvulsants. So again, if people have seizures, sometimes that's a tough drug. We can't just necessarily get rid of it, but that's kind of our cue that it's like, what's people's baseline levels for Depakote, phenytoin, phenobarb, some of those older ones. Well, let's recheck levels and see if we're higher than we need to be. Anti-Parkinson's medication. So we're adding maybe too much dopamine. So again, I'm not a big fan of dopamine agonists like the ropinirole and things in restless legs, because of can contribute to psychosis just in general, but also to delirium. Antidepressants, mostly tricyclics because of the anticholinergic activity like an amitriptyline. But we also need to think about antidepressants and how they can affect electrolytes. So SSRIs, SNRIs can cause hyponatremia. And that's more common in older people and specifically in women. And so if we're new on SSRIs and we have somebody that's maybe delirious or confused, it's part of why we take lab work, and check and make sure that sodium's fine. Corticosteroids, people that are at high risk, if it's clinically able to not, do super high dose, if someone has, asthma or COPD, we might need, a certain dose of prednisone, right? But if we're able to maybe decrease that dose, depending on the indication, we should do that as far as prevention. Or if we're seeing delirium, recognize that can cause it, and maybe we can taper a little quicker than we wanted to. Digoxin, again, not used as much anymore, but kind of a classic one that can get too high, so we can easily check levels. We can check people's heart rate. If that's getting too slow, maybe that's a good indication we can lower that medication. H2 blockers would be like our famotidine. And so they have some anticholinergic activity. And so especially those drugs are renally cleared. So if people have really bad renal function, maybe we're just dosing them too high, and again, can add to that anticholinergic load. It's not like using diphenhydramine, but it still can add up. Antipsychotics, Again, a lot of times used to treat, but can also cause. And it's more of the old time antipsychotics like chlorpromazine, or which is Thorazine. That one had a lot of anticholinergic activity, or thyroidazine, like Mellaril, isn't used anymore. And that's kind of why Haldol has been studied the most, because it really doesn't have a lot of anticholinergic activity. You know, it has a lot of dopamine blockade, um, but not so much as far as anticholinergic. But again, are things getting better or worse as we use antipsychotics? All sleep medications, you know, again, can contribute, and then skeletal muscle relaxants. And my point here is, because we try to limit opioids so much, I have seen an increase, you know, in our use of cyclobenzaprine or baclofen or methocarbamol, and a lot of those medications have anticholinergic activity and can add to the potential for delirium. So we kind of maybe have hit on a lot of these as far as who's susceptible. You know, it's those, you know, older adults. Again, things cross that blood-brain barrier much more easily. Add on if they already have dementia or some kind of cognitive impairment, that's going to put people at either further increased risk, and we better double up on our prevention strategies. If we don't have our glasses, no one knows that we wear contacts, and we're not using those, or glasses. That can increase the risk. We need our providers figuring out what those infections are, and treating those things. Also, if they have depression, and, you know, again, alcohol or substance use can add to it as well. So some good methods of prevention, and that's where we just have to be really good clinicians, because the pain meds, you know, we're blaming them, but also sometimes we forget to treat pain, and that there's some other options sometimes for pain. You know, should we be scheduling more Tylenol? Is there some topical therapies we can use, you know, that aren't opioid, that maybe can decrease our need for some of the meds that increase the risk? I think that drug withdrawal is definitely an overlooked thing. We need good med rec. What are those meds that they were taking all the time, and now because they're in the hospital, we kind of said to stop everything? Well, stopping everything isn't always the best. You know, if we know that anticholinergic med just got started and that seems to be the issue, yeah, 100% get rid of it. But for most psych medications, unless, you know, we have something major going on, we usually like to taper those off, right? By 25%, because we can have so many withdrawal symptoms. So just, we have to keep that all in mind. Also, you know, maybe it's around surgery and those type of things, and we've stopped a lot of their blood, you know, insulin or diabetes medications, and now our blood sugars are totally out of whack, and that's causing our electrolytes to be, too high, too low, etc. There's been a lot of medication studied, but unfortunately, you know, most of those things have really not shown a reduction, and maybe not the best time, you know, to be adding things, you know, based on the current literature. Non-pharmacy strategies, you know, part of probably why they looked at melatonin is because the sleep wake cycles can get out of place and those type of things. I was on a meeting yesterday where we were talking through like a use of sleeping medications, and at some facilities how then all of a sudden they're using their sleep meds at 6 o'clock at night. Well, how much of that drug is still left at 3 in the morning? No wonder the person is up, you know, most of the night, and those type of things. They're not really using the medications that we should be using anyways, but then maybe not using them maybe correctly, you know, and how many hours are they sleeping during the day? Making sure we address hydration, because that's part of the metabolic and electrolytes getting out of whack. So in the hospital, a lot of times it's, you know, making sure we're doing fluids and those type of things, you know, long-term care, home, assisted living, that making sure that people have access to fluids, and that they're actually drinking them. Have we checked on whether we might not have a retention issue as far as constipation, and that's adding to our problems? We talked about the infections. It's shown that encouraging mobility as people are safely able to do that, that's going to help, and nutrition support.
We have a question. So Mabel is asking, so is Haldol first choice as antipsychotic?
Yeah,
Any
yeah,
others?
yeah. Great question, and kind of foreshadowing to upcoming slides. But yeah, haloperidol and olanzapine maybe have the most studies. But the problem is we don't have a lot of good studies, right? It's not the best group to when it's so difficult to actually figure out if it's true delirium or not. That's part of it, in the studies. And then a lot of the medications we use are generic and you know um, a lot, maybe not as much funding available to kind of study some of those medications. So that's kind of a difficult one. And I'll spend a little bit more time here coming up. But great question. And so that's why we really need our providers to help. And what we can do is, um, you know, others in the healthcare team is really asking, our providers to really assess what's going on, or bring in specialists if we need to figure out exactly if it is a delirium we're dealing with. It's really important to recognize and prevent delirium as well, not just from, you know, um, the individual patient, but it costs way more money to treat people that have delirium. They have longer hospital stays. They get way more tests, lab work, X-rays, MRIs, those type of things. Um, and they tend to actually add more and more medications, right? Things aren't going well. Sometimes the tendency is to let's add things rather than peel back some of the medications, and which actually might be more helpful and those type of things, and then can add to fractures, aspiration, dehydration, pressure ulcers, all things that again are going to increase that hospital stay. Yeah, and sadly, there's not more options for the medication management, and where we really like to look at what can we kind of peel back. And so the non-pharmacy things, I think we're going to cover most of these maybe in some of the slides coming up. But there's some good behavioral management things that people could maybe Google and download if they wanted to look a little more in here. But I like the acronyms here, the DICE, the describe kind of what's going on, investigate, what meds are new, what things maybe started, what stopped, create a plan and then evaluate. Are things getting better or are they getting worse? Otherwise the tolerate, anticipate the delirium could be an issue, and then let's maybe not agitate people on top of it. So med use in delirium, and if we have somebody that's hypoactive, they're sleeping way more, they're not eating well, and those type of things, usually it's not adding more meds. It's usually trying to take away some of those anticholinergics and those type of things. I probably should have mentioned earlier too that how long does delirium last? For most people, even older adults, it's more like less than a day. But you know, up to 15% of older adults still have delirium after 10 days. And so it's a huge range of how long it can last. And so when you think about those days, think about sometimes how many transitions people go through. They were in their home, they had surgery, now they're getting delirium, and maybe not recognized. Not a lot of people get to stay in the hospital 10 days. And so now they transfer to rehab or long-term care facility, and so now we're dealing with it there, and maybe we don't have all the information and know what's going on. Like I alluded to, most studies that they're out there as far as delirium, if people are a threat to themselves or others, they're aggressive, they're hitting, those type of things. When we've done all the non-pharmacy things and those type of things, we might need to use an antipsychotic, right? And so the most studied are haloperidol and olanzapine. But all the things I've read, it really seems like most any antipsychotic can be used. So again, match up maybe which contraindications people have, or um, other meds that they're on. So if somebody is having a lot of trouble sleeping, um, maybe that's where quetiapine maybe makes a little more sense. We know in the long-term care world, we're gonna have to do a lot more documentation on some of that. And so maybe we use that medication. Olanzapine's been studied a little more, but it actually has a little bit of central anticholinergic activity, so that's probably not my go-to. Risperidone might be fine. But again, another fairly potent dopamine blocker like haloperidol. And because we're talking specifically older adults, we're not saying that they have bipolar or schizophrenia. We're usually saying pretty low doses, right? We're using like 0.5 of haloperidol, 1 milligram of haloperidol, not 5 or 10, especially to start. We might be using 2.5 of olanzapine or 12.5 of quetiapine, using those lowest of doses, titrate, and being ready to titrate up fairly quickly. And then if things are getting worse as we titrate, let's go back down and try something different. And I think that's probably the biggest frustration, right, outside of hospitals, is if we don't have a psych provider available. Sometimes there's not providers that are willing to we got to keep changing the doses, right? It's like we maybe pick the right med, but we're not titrating it correctly in those type of things. They've also looked at gabapentin, because it's thought that, the GABA system, glutamate might have some, potential as part of the issues. But gabapentin really didn't seem to show an benefit. It can help a little bit of anxiety, but I'm not a big gabapentin fan, just because, it's another CNS drug. We're adding it to the mix, and we're not really sure if it's helping or hurting many times, and it tends to get left when there's been no clear benefit sometimes. They actually did a study where they tried doing a cholinesterase inhibitor to increase acetylcholine basically in the brain with rivastigmine, and then they did that versus haloperidol, but there was higher mortality in the rivastigmine. And so those acetylcholinesterase, I mean, it's not the best time to be adding those drugs when somebody's truly having delirium. If somebody has dementia, adding these meds and over the long term, does that decrease delirium? I mean, that'd be a good study to look at. But it's like in the short term, we're probably just going to cause more side effects, and usually it does not going to work immediately. Benzos, again, limited role, but if we have no other options, sometimes we have to kind of try and use them smartly, and again, be really ready to peel back that med if we have to. And then the central acting drug that other slide was kind of alluding to was a man, I can't talk right now. The old blood pressure medication, the alpha 2 blocker, guanfacine, and they looked at that medication. But again, as you'd expect in older people, we really not want to use it in people that are at risk for bradycardia or hypotension, because it could just add to that, and increase orthostasis risk.
We have a couple of questions from Mabel.
Perfect.
She wanted to know who provides the DICE and TDA management, and and then okay, go ahead.
Yeah, great question, and I don't remember off the top of my head. So if someone could Google those and throw them in the chat, that would be greatly appreciated. Yeah, sorry I didn't have that right on there.
And then she wanted to explain. I don't know how to pronounce it. Sorry, guanfacine.
Yeah.
What for? And classification.
Yeah, mechanism that it is that alpha 2 central agonist. So alpha receptors in the brain, it works on that to basically decrease blood pressure in the periphery. In its usual mechanism for blood pressure, but because it works within the brain, they've noticed that it can help with impulsivity, anxiety, and those type of things for psychiatric type concerns. And I think that's probably where they got the thought behind trying to use it in delirium. So another great question. And so what are those other references? Having our download of the Beers criteria and all the charts that are within those. In Europe, they have the stop-start criteria. That can also help us if we want to gain more knowledge on that. There was a big study that listed in long-term care, the people that develop delirium, many of them are on potentially inappropriate medications that can add to and cause delirium. So older adults, if they're on 3 or more of these potentially inappropriate meds, more likely to have delirium. And so that's why, people might get sick of it, but it's why we're always trying to lower doses, trial off certain medications and see if the problems and the reasons why those medications got added are still there, because we're worried about over time. Today they're not having delirium, but now as they get older, other meds are added. We just keep adding to the potential for some of these geriatric syndromes, or like delirium. And so, yeah, prevention is key. And so then these last few slides reference the senior care article that I just thought did a really good job of going through the different areas that can contribute to delirium, what intervention we can do, and then what recommendations there are. And so, never enough funding, right, in healthcare and those type of things. But if there's family that are able to be involved, depending on what our setting is and those type of things, or if we maybe spend a little money in that area, maybe that helps us, not have people in the hospital as long, which can be more costly to our facilities and those type of things. Should have listed maybe some of the delirium screenings, but like a common one is like the CAM, or the confusion assessment measurement, which takes about 5 to 10 minutes. I think there's a brief CAM that's more like 2 minutes. But having these tools available, again, I'm not really the expert, and maybe someone else can give us more guidance in that area in the kind of question and answer session. But if we have those things and recognize delirium more quickly, we can, talk to the nurses, the providers, the pharmacists to try and say, how do we get out of this place, type of thing. How important hydration is and how important it is to document it. So those of us that are trying to work up what's going on, is this person drinking? Pretty common sense, easy thing. But if we're not clear, we might skip that step and try things that maybe have a little more risk. Increase in mobility. We talked about the medication management, and depending on the setting, right? For long-term care folks, lean heavily on your consultant pharmacist. If it's assisted living or if it's at home, we might want a pharmacist that specializes in that area. Not all pharmacists specialize in kind of meds for older adults, or kind of the clinical application, or how to taper some of those medications. Same reason you wouldn't ask the orthopedic doc to address the cardiac meds, or their psychiatric meds. It's kind of that same thing. We all kind of have the things that we're good at. Some good examples on how to orientate people to time and place. It's kind of good reminders, especially when now people are in facilities they've never been in, totally out of their surroundings. Anything that can help them get back to feeling normal is just going to help us get out of that delirium state or prevent it. Pain management we touched on, and then not forgetting, eyeglasses, hearing aids, all of those things that can also contribute as well. So staff awareness, doing talks about delirium, discussing it at team meetings and those type of things. Stress management, all kind of the common sense things that, it seems like we never have enough time for sure. So whenever we have that change in mental status, it's, gather the troops, let's get everybody kind of working as a team and figuring out all the different things. Because usually, like most geriatric syndromes, usually it's not just one thing. It's, it's a combination of things, and we might need to do a little bit of everything to get out of that delirium state. Avoid attributing that it's like, well, this person has dementia. No wonder they're acting like this. Well, it can be superimposed on there, right? And this might still not be their normal. And so we need to be assessing that. As clinicians know, we shouldn't really assess for dementia during acute illness. That's not the time. We're more assessing if this is delirium or not. Hypoactive delirium often presents eating less, sleeping more, having changes of mobility, and that's the one that's much more overlooked. Especially in our long-term care world, we really try to stay out of documenting agitation, because Department of Health and our long-term care regulations don't like that. But in whatever setting, it just is too non-specific, right? One person's agitation is that they're aggressive and calling 911 and hitting out and all these sort of things. And another person's agitation is, they ask repetitive questions, or they're having some anxiety, or they're a little restless. And so it really just doesn't tell us what's going on and help us with our plan going forward. Using those behavioral management, and so we kind of went over some of those tools, and then let's avoid adding medications until we've kind of ruled out